I want to talk you about our experience with fusion technology with MRI and ultrasound, especially for sports medicine. Fusion, you can see the fusion in the image now. It's, you can, when you are doing fusion, you are navigating within the MRI in real time, and it could be very useful, especially for teaching purposes and also for injections. Please, the presentation, Marco, Peter. Okay, thank you. This is a work of a team in sports medicine in FC Barcelona, and really everyone here is used to some kind of fusion between anatomy and the image, between signs and symptoms, and between X-ray and CT. We could speak about some kind of manual freehand fusion of images as cognitive fusion. The ultrasound operator simply aims the use proof at the same area when the MRI shows a lesion. It is simple, intuitive, quick, and requires no additional equipment beyond the MRI and the conventional ultrasound proof. But it has some potential errors. In fact, you can see this injury in the MRI here. And we can do this kind of cognitive fusion to reproduce the same injury in real time. We are doing this cognitive fusion every day in our work. But I want to talk about real fusion. Why? Why for sports medicine this kind of technology? Because the injuries are very frequent in sports during the year, and most of them are not severe. However, they often result in breaks from training, from the competition, and considerable medical cost. Imaging studies play a fundamental role in diagnosis regarding surgical management, rehabilitation process, and return to play. In recent years, the clinical use of musculoskeletal image, ultrasound, and MRI has changed and has improved a lot the diagnosis capability in sports medicine that is mandatory for better decisions. For fusion, fusion is a combination of MRI with a real-time high-resolution ultrasound to improve the visualization of musculoskeletal sport injuries. The patient must have a previous acquired MRI or CT and to do the ultrasound in real time. This linkage is accomplished by selecting two or more easily recognizable anatomic landmarks, looking at plane and registering the images on each of the two studios. Once linked, we could see the images in real time in the same screen, side by side. And it's very, as you can see, it's very accurate. It has been done for liver and prostate, as you know, but it's not well implemented in musculoskeletal medicine till the moment, and it could be very useful for guiding injections. About the technical aspects, we use this Toshiba Aplio 500 that has two antennas and works with a tracker system like a GPS to move around the exploration. The MRI position must be taken into consideration, and after matching the images, navigate within both images at the same time to much better continue. You can continue during the exploration, refusing images to improve the image. The best anatomic landmarks are tendons, vessels, and bony shapes, of course. This is it's recommendable to start with these identifiable images, such as this 18-year-old football player with chronic anterior pain in the ankle. MRI and ultrasound showed an anterior bone spur formed in the tibia, causing the chronic pain. So anterior impingement syndrome was diagnosed. It's easy recognizable in both images. Landmarks are very easy to choose in the bone shape. Of course, we have described some landmarks that are usually use it in the ultrasound studies, for example, the low head of the biceps in the shoulder, in the anterior thigh, the rectus femoris tendon, intramuscular tendon, and the anterior inferior iliac spine, in the ankle, the anterior tibial tendon, the talar dome, etc. In the normal knee upper view, we use the tibial band here and here to fuse the images at the Gerdi tubercles. You can note that the band insertion is very easy to identify in the medial knee here, in the lower view, here. By zooming into the image, we were able to assess the medial collateral ligament by ultrasound with good resolution, but it gives a limited field of view, restricted to the most superficial layers. And after that, we can navigate within the MRI to look in any plane we want the internal anatomy of the knee. This is an axial view of the medial patellofemoral ligament in front of the plica, related to the synovial recess, as you can see, in both sides, the same images. The same for the posterior sagittal view of the posterior bone shape of the tibia plateau, and the posterior cruciate ligament in both images. This is an image of normal rectus femoris in the proximal area with the direct insertion in the anterior inferior iliac spine. Moving distally, the indirect tendon of the rectus femoris is well shown on the MRI and usually not visualized enough in the ultrasound because the critical shadow in these eyes, but we can understand if the injury of one of these tendons affects one, the other, or both, with this kind of images. If we go distally, we can see the direct tendon and the indirect tendon at the corresponding image, in this case, hidden by the shadow. This is a 24-year-old athlete with history of chronic shoulder pain, instability, who has had an arthro MRI of his right shoulder. It's a risky approach to try to use one arthro MRI with fusion, but it's feasible. The long head of the bicep was used as a landmark to fuse both images, and in the posterior approach, we use the infraspinatus tendon as a landmark. An injury in the posterior superior labrum here. It's very easily recognizable in the arthro MRI, and in the ultrasound, in the dynamic ultrasound, we could see that this injury is totally unstable for the patient. The injury itself was useful as a landmark, as in this case. In this 18-year-old football player with a scar in the rectus femoris, intramuscular, in his intramuscular aponeurosis. The fused images shows an enlargement of the tendon. It's possible to assess the delayed muscle soreness by images. This image is from a 22-year-old synchro swimmer of the national team with serious pain in her elbow, in the anterior plane of the elbow after one heavy training session. The MRI shows this amount of signal in the brachialis muscle. It is correlated with this change in the ultrasound image 24 hours after. Better understanding of the hamstring injuries, as we have heard in some lectures before, is challenging, especially for football players. The most important factor in determining the severity of the injury is to identify the central tendon. If the central tendon is torn or not inside the muscle belly. In this case, this is an 18-year-old football player, another young player. We can see the central tendon and the semimembranosus and its relation with the ultrasound. We go down, following this is the semimembranosus, the tendon. We can see better the semitendinosus muscle belly and the central tendon related to a little enlarged in this image. Yes, in this plane, we saw that this tendon has a split, vertical split, and its correlation with the ultrasound. And when we go down, we are seeing the same plane. And finally, in the left, down in the left, we can see the tendon with the distal part of the biceps femoris. It's this tendon. It's This is a case of rhabdomyolysis after exercise, after 100 kilometers training session by running. In 1 week after the training session, we can see this amount of signal in the quadriceps muscle, not the necrosis focus of the vastus medialis of his right thigh, and his corresponding image in the ultrasound. In this image, you can see a 19-year-old female swimmer with a 3-week anterior pain in her right shoulder. The MRI shows a cyst under the coracoid process, which is hidden in ultrasound. But this cyst is very useful to do an injection inside. As is hidden, we correlate the body images in real time, and we put the injection guided for infusion images. Here, the same for the sacroiliac. In fact, the sacroiliac joint injections has been described in the literature, and it's very easy to recognize the same shape of the bones in the both images, both in one side and in the other. It's the same for the facet syndrome injections, posterior facet syndromes. In this case, you can see a scar inside the rectus femoris in the left side, and the corresponding image in the right one, in the ultrasound. We can see the same injury in real time, and we can navigate inside the injury and change the plane easily going. And some moments it's easier to recognize the injury in the ultrasound, and sometimes it's easier in the MRI. You must not forget that the compression only deforms the ultrasound site, of course, because the MRI is previously acquired, okay? And the vessels and the branch of the vessels are very useful landmarks, because in both images you can see that they are both working in the moment, okay? This is a kyst, very little meniscal kyst of a patient, but very painful. It's difficult to recognize in the ultrasound, and injecting and correlating with the MRI. It's easier to recognize, and also to explore the internal meniscus architecture related. This is a PCL rupture, tornet, that is easy to see both in ultrasound and MRI, and also to check with fusion. This is an intertrichetum piriformis arthropathy that we try to inject hyaluronic acid inside, guided by fusion. You can see how the hyaluronic is entering between the two bones, and we are correlating in the same moment in a young basketball player with pain in this ulnar part of the wrist. This is a soleus injury, very difficult to see how the architecture of the soleus is distorted in this kind of tear. And we can correlate with this myofascial injury and the correlation with the vessels. We use also for assessing the injections, and this is the ischial tuberosity, the two shapes of the two tendons, the semimembranosus and the central tendon of both, and the central tendon has a split injury because inside them, that it is recognize. We can recognize it changing the plane. It's easy to recognize inside the MRI, but not the same in the ultrasound. We can see this, the injury in this case. And to inject a PRP inside the injury, we use the fusion for a better here we are injecting inside the belly of the tendon related to looking for this split injury, as you see. And you can see how the tendon is enlarging in the ultrasound, not in MRI, of course, when we put the PRP inside the tendon, inside the split and surrounding this. Finally, you must know that it has a hard learning curve. You must respect the perpendicularity during the synchronizing. The patient must be totally still to avoid errors. Time to match landmarks improve fast. When you start with this technique, you must take more than 5 minutes, but when you are in 2-3 sessions, in 1-2 minutes you have done the landmarks, and you can synchronize the image as much as you need. It's an excellent tool in deepening ultrasound knowledge. It has been very useful for the clinics that in Spain we are doing ultrasound. The use of fusion has improved a lot our knowledge of the internal structures. As musculoskeletal ultrasound is fundamental for sports medicine, and also MRI is good for the better anatomy understanding, the combinations improves the decisions timing. As in the cones, you need high quality MRI images. Changing planes disharmonize sometimes the exploration, especially in smaller joints. Elbow and ankle is difficult to maintain the axial plane because it's irregular surface. And in small joints, like the fingers, the arterial pulse of the sonographers makes the image pulse as well because too many exactitude of the tracker. Maybe it could change in the future. As pros, ultrasound is very useful for follow-up, navigate within the MRI, allows to look for shadow and hidden structures like cartilage, labrum, or meniscus. Is useful for guided injections. And the acquisitions 3D MRI allow us to change from plane to plane without losing resolution. It's good for us in the moment, it's good for sports medicine, and better landmarks need to be described. And this is finishing. And I want to invite you to the next football medicine conference that we organize on May next year in the stadium, inside the stadium, maybe look in the stadium in real time also, like fusion, and to talk about new technologies surrounding medical football medicine. Thank you very much.